Atrial embolization after a transcatheter mitral valve. Transcatheter mitral valve replacement, TMVR, using the valve-in-native valve approach has become a well-established alternative option for patients with severe primary and secondary MR considered at high or prohibitive surgical risk. Echocardiographers must be able to provide a comprehensive assessment immediately prior to, during, and after implantation in order to define not only success, but also problematic anatomy and inadequate deployment. A 78-year-old woman with history of non-rheumatic mitral stenosis and regurgitation, hypertension, pulmonary embolism, aortic stenosis status post-transcatheter aortic valve replacement with a 23 mm Edwards, and coronary artery disease presented for elective TMVR. Past surgical history included prophylactic alcohol septal ablation 2 weeks preoperatively to treat septal hypertrophy, 2.29 cm, and subsequent permanent pacemaker implantation for complete heart block. On a planning multi-detector computed tomography scan, the patient had 270 degrees of circumferential calcium in the mitral annulus. The lateral mitral annulus calcium thickness was measured as 10 mm and medial annular thickness was measured as 11.1 mm, with a calculated mitral annular calcification score of 8. Given her comorbidities and severity of her mitral annular calcification, TMVR was chosen rather than open surgical intervention. A transapical approach for TMVR was planned because the patient had anomalous venous return with the absence of a direct inferior vena cava to right atrium blood flow, with blood return via the hemiazygous vein. A 26 mm Sapien 3 Ultra valve was chosen due to her calculated annular area of 4.55 cm by planning CT. Pre-implantation 2-dimensional and 3-dimensional TEE examinations were performed and a 26 mm Edwards Sapien 3 Ultra valve was deployed with 15% oversizing. Post-implantation TEE images were obtained. The patient was extubated and transferred to the intensive care unit in stable condition. Upon arrival in the intensive care unit, the patient experienced immediate hemodynamic distress, with worsening respiratory failure, flash pulmonary edema, and acute heart failure. The patient was reintubated, and emergent bedside TEE revealed an embolized mitral valve into the left atrium, severe mitral regurgitation, and intermittent obstruction of left atrial outflow. After the valve embolization was identified, The patient was emergently returned to the operating room and the mitral valve was replaced with a 29 mm St. Jude epic valve via a traditional midline sternotomy, bicaval cannulation, and cardiopulmonary bypass. The patient had an uncomplicated intraoperative and postoperative course, with follow-up TEE showing no paravalvular regurgitation, and a mean gradient of 5 mmHg across the replaced mitral valve. The patient was discharged 1 week after her surgery. In conclusion, it is crucial to understand the role of multimodal imaging tools, particularly TEE, for procedural guidance and post-procedural minimization of complications. It is essential that interventional echocardiographers be able to identify patients at particular risk of valve embolization by identifying concerning intraoperative TEE findings.